Hi everyone, my name is Claudio Peru. I'm the Principal Endodontist at UK Dental Specialist. And welcome to the UK Dental Specialist podcast, your go-to source for all things dentistry and beyond. From essential patient information to exclusive interviews with some of the most influential figures in the dental world, we have got you covered. Whether you are passionate about oral health and want to understand how to achieve your best smile, or you are a dental professional looking to stay ahead with expert insights and clinical perspective, this podcast delivers knowledge, inspiration, and motivation to help you thrive. Join us on this journey as we dive into the latest trends, inspiring personal stories, patient-focused advice, and everything happening in the world of dentistry. Welcome to UK Dental Specialist Podcast, where expertise meets excellence. Hi everyone, so welcome to the first episode of UK Dental Specialist Podcast. This is a show where busy dentists as well as experts in the field of dentistry, they will give their insights and cutting edge advice about what's going on in the dental world. So I'm your host, I'm Claudio Peru, and I'm a specialist endodontist. I'm the principal at UK Dental Specialist. So I will be hosting a series of podcasts, and today's episode will kick off with a familiar face that many of you already know, and he's also an esteemed colleague. Works with us at UK Dental Specialist, and is Dr Kostas Karagiannopoulos. Now, I know Kostas for quite some time because back in the days when we were a little bit younger, we started our postgraduate training at the same time. I think it was exactly the same time, right?
About 20 years ago.
About 20 years ago. Possibly a little bit more than that.
Maybe
more.
Yeah,
a little bit more, yeah. And I was studying endodontics at Guy's Hospital, and Kostas was studying prosthodontics at the same hospital. So we used to meet very often at the sort of after postgraduate meeting club. There was the pub, I don't remember the name, Hilltop possibly?
Hilltop.
Yeah, to discuss mainly teeth, if anybody believed that. But anyway, so Kostas is a very familiar face in the dental world, is also known as the guru of cosmetic dentistry. And I think he's very humble, but I'm sure many colleagues will agree with me. Gave so much knowledge in the field of cosmetic prosthodontics, and I've been very lucky to work alongside him in very difficult cases, and I always get amazed about the planning and the execution of the plans, and all his cases, they look amazing. So I'm sure today he will give us lots of advice on, some tips on something that we might not hear in a lecture, but hopefully we can share with all you guys today. Now, Kostas, thank you very much for your time. You had a very busy day today, so busy specialist.
Glad to be here.
So tell us a little bit about yourself. Your career, how you got to this point since the beginning of dentistry for you.
Sure. Thank you for having me. My name is Costa. I'm a prosthodontist, and I've been in this country for now 30 years. I came back in 95 to study dentistry, and I come from Greece originally. The love for pros came back at undergraduate at the Royal London, where it was taught so badly that I felt that I had to learn that subject, and that inspired me to learn about fixed and removable pros. So I knew all along I was going to do the specialist training, and but education was always ongoing, and then I pursued a lot of training in the United States. After completing my specialist training, I took on a teaching position at King's College, where I was a consultant for 15 years, and I've always loved education. It's very rewarding. I always love the interaction with the students. I've now recently joined UCL in the pros department because I missed the teaching. And
you betrayed, guys.
Well, I jumped across the river, but it doesn't matter why. And I've been here at UK Dental Specialist for, I think, some 8 years. And it's my only clinical position. And other than here in uni, I do some private education with my company called ProsthoWorks. And I want to give to other clinicians and dentists as much as I can. It's I've still got a drive and a spark for it. I don't know how long it's going to last. And but education has always been the core of my career in dentistry for 25 years now.
Thank you very much, Kostas. Now, obviously, I work with several prosthodontists, and I have introduced you, I think, with a term that I think I just made up, like on the spot, a cosmetic prosthodontist. Now, do you agree with that? Do you think is a representation of, or all prosthodontists are cosmetic experts?
Well, probably I would take it further by saying that all dentists are cosmetic dentists.
Fair enough.
Because no one wants to do the opposite. Everyone is thriving for good aesthetic results. And if anything, from the patient's perspective, with the information that patients can retrieve from Google and social media, their expectations are high.
Yeah.
So whether it's a GDP or a specialist, it's hard not to delve deep into the aesthetic world, irrespective of materials. And that is something that you're not gifted with. It's something that comes with mistakes, a lot of training and experience. So whoever in this country or abroad has excellent aesthetic results and teaches in the lecture circuit has done tons of mistakes in order to get to that position. And same for myself. I have done a lot of training and mistakes in order to deliver good aesthetic results. And that is a multidisciplinary effort of working with excellent technicians and nurses and reflecting on previous cases with dental photography and learning through that. So it's not something that is taught at university, I'm afraid.
Not yet, maybe. So just diving straight into, what I see you doing a lot, which I'm sure lots of the listeners will be very interested about, is the use of composites to achieve, especially even cases with full mouth sort of rehabilitation in terms of the aesthetic results versus porcelain that was used probably more 10 years ago, 15 years ago. So you use a lot in the last few years. I've seen you using a lot of injection molding techniques, and that's something that I think lots of dentists will be very interested about. Tell us a little bit more about this technique, what it's about, and what cases you think you're doing more using this technique compared to, let's say, 10 years ago.
Good question. So I've started implementing this technique about 2018. It's about 7 years now. And I've been teaching it for about 5 years. Why composites and why fully guided? Yes, I have a bit of a bias in terms of postponing tooth preparation, cutting down teeth for indirects. So
from an endodontist point of view, that's bad news. Because I guess you can retain vitality much, much more. Because I still remember those days where veneers were actually 3/4 crowns, and to achieve a good aesthetic result, you had to cut teeth down. And I was, really busy doing central incisors and lateral incisor endo, every time. But I guess that's one of the main advantages of these techniques, a very conservative approach.
yeah, with indirect dentistry, with ceramics, no matter how much they have evolved and we have master technicians, we need to shave the teeth down. And what I see in terms of a change on the patient front, and what they discuss and what they expect is that they want a good looking result. They want it done quickly, avoiding orthodontics if possible, avoiding shaving the teeth down, and their expectations are high. So composites come into this where we can just do some additive work and make the omelette, but without breaking the eggs. So trying to give an aesthetic improvement only by adding onto the teeth. Now, it's not a complete substitute because there's longevity implications, but patients are happy to explore the options of not shaving the teeth down and postponing it for later. So, yes, when ceramics are done, we have to shave the teeth down. Whether it's 5% or 40%, it doesn't really matter. Now, as far as injectables specifically, in the process of teaching back at university, I was experiencing a 3-month prep period from the students of planning an additive case, only for them to go completely freehand after 3-4 months of doing all the architectural work and all the civil engineering through wax-ups and face bows and blah, blah, blah. So I had to find a way where we can replicate and copy-paste the pre-approved result.
Yep.
So that was the spark for this technique. And the main two indications that I use it for now is aesthetically driven veneers, people who want some changes on the teeth, and tooth wear. So it's a technique which is popular because you predetermine everything in advance so that it's not down to the clinician's skills. It has its limitations and it's not for everything. Well, such as
So when would you think that it's not a good idea to go into sort of injection molding, for example?
Any cases which involve the patient showing any form of parafunction.
Right.
It's we're using a flowable composite, which is very strong, but still it's a bit weaker than paste composites in some respects. So expecting that on a patient who does grind their teeth as evidence of this, and that, hey, we're just going to slap on some composite and you should expect 5 or 7 years, which is the normal expected longevity of composites, that is not realistic. So I was doing quite a few cases like that 5 years ago and giving the normal consent, but I've now learned that things will break and consenting is massively important, and that patient conversation needs to be extensive and in writing so that the patients...
So do you have informed consent in writing for
Absolutely.
every single...
Absolutely. I have a specific one for composites. It's not limited to injection molding, and it raises the need for high maintenance.
And have you ever come across a patient that once you share the sort of limitation of composite, for example, the longevity,
yes,
any patient that said, oh no, I'm looking for something very long term.
Absolutely.
All right.
Absolutely.
Okay. So something that's
right? Part of the consenting process. So if I very briefly compare and contrast composites to ceramics, the ceramics are going to have a high longevity, low maintenance. You're not going to be expected to see the dentist non-stop, maybe just a hygienist, and it's a big financial investment.
Yep.
In the world of composites, you're going to be circling the airport. You're
Right.
going to be expecting chippings, you're going to be expecting repairs, polishing, 2-3 hygiene visits a year, and you're going to be expected to pay for these repairs. So the consenting process needs to be watertight, because just because we're doing composite for somebody who doesn't want their teeth shaved down, we're not going to be held responsible for lifetime repairs for free. So, of course, that needs to be in writing, and patients understand this. And with good consenting, when they break a tooth, they don't say that, hey, Costa,
I never knew
your
that.
composite
Right.
broke. I broke my composite.
Right.
So they own
They
the
take
maintenance.
some, responsibility. Well, the industry is booming in terms of, composite veneers or bonding or whatever we want to call them. But I'm sure you see lots of patients that had previous work done before that had to be rectified, or they were unhappy with the result. What sort of problems do you see from when things go wrong out there and patients that come to you because they want to rectify the problem, what sort of problems do you see? Is it wrong planning, wrong execution, expectations way too high, consent not gone through? So what is the main complaint from patients when they're dissatisfied and they come to you later on?
I'm going to start by saying that my own cases that I did about 5 years ago,
Right.
I need to redo them. It's composite, it's not marble, and it will stain, it will chip, and it will wear. So if I could see something different, I would like to see these composite makeovers done exclusively on patients that have zero active disease.
Right.
That is still not the case. So on the name of a quick aesthetic result, quite a few cases are done, whereas there is some perio and caries potentially. So the second remark has to do with very young patients, that these composite veneers, they're not reversible. I make that very clear in my consent forms, so that you commit to this as much as to ceramics. So if you are starting having cycles of composite build-ups in your 20s, these people need to be very aware of that. And
that's, I guess, in your informed consent.
Absolutely. I try to
When you say
deter them.
reversible, for the non-expert like myself, so I look a little bit deeper than you inside root canal. So the idea that I've got in mind is that you can remove the composite under high magnification.
Absolutely. I can
but
remove my own composite work to a very high standard.
So why do you say it's irreversible?
Because I do not want patients to think that, hey, if I don't like this result, I will come in a couple of weeks, I will have them removed,
right. Okay.
And I will get
Makes
a full
sense.
refund. It just sets the expectations right, that you commit to this. It's not like fake nails that you can just unclip them and go back to the beginning. Just to give the gravity to this procedure, not for any patients, young or old, to take it lightly. They really have to understand the long-term implications.
I think it's part of the issues, patient expectation. And also, I'm sure you agree with me, that there is a trend where lots of young dentists, understandably, they are attracted by, injection molding and, similar techniques, composite veneer in general, composite bonding. I think that's one of the most popular terms.
Yep.
And they're diving straight into it after BDS. I don't have a particular feeling about dentists specializing quite soon in a specific field, but have you got any concern about this trend? Because it seems that the new generation, obviously they are attracted by aesthetics. I think it's part of being young and looking great and relating to young patients. That's probably part of the issue. Social media, they play a huge role, and the image that we get bombarded with every single day. But if you're looking at a young dentist, would you say, why not? So you finish your BDS, forget about, the root canals, that you can sort of micro specialize in this field, get good at it. I see no problem with that. Or would you say, that's not my best advice for a young dentist? What's your view on that?
Well, firstly, when somebody completes their BDS, they have the full freedom to do any aspect of dentistry. And many will go towards aligners, many will go towards general dentistry, many will go towards composite bondings, let's say. What has changed, other than the recent trend from dentists, is that patients now do request this. 15 years ago, nobody was coming to me asking for composite bondings. They didn't even know what it is.
Yeah.
I had to explain it with all sorts of bad descriptions. So now it is a thing. It is something that patients request. And on the notion that, hey, if you're not going to give it to me, I'll go to somebody else and they're going to do it. It's become established, popular, and it will stay so. Now, yes, the maintenance and the implications for the long term are significant, because they don't last for that long. So I'm not gonna give a direct message to what young dentists should do, but if anything, I would say that unless you have a few solid years of experience of seeing your successes and your failures, doing good basic dentistry well and eliminating disease and doing the main aspects of general dentistry, you may not really appreciate the downfalls of these composite makeovers.
Right.
So it's
So looking at the perio, the endo, the overall
absolutely,
functionality of the
and
mouth.
particularly occlusion, because no matter what you do with occlusion in terms of training, you're only going to learn it really from your own cases and your own failures. That's the best educator for occlusal problems. And when you slap composite on, yes, you're going to be getting some chippings, and it's usually not the material's fault, is an occlusal problem. So with the injectable techniques, you can scan somebody, you can take some photographs, send a case to a lab. They're going to do a good wax up or a dodgy wax up. It doesn't really matter. And then the actual implementation, the execution is not that hard. So it's a skill easy to implement. Yes,
You
complaints.
need to put into perspective of the whole overall treatment plan with everything else.
Absolutely,
in place.
and to be able to do this ethically and comprehensively with the right consenting, a good few years of just solid general dentistry is needed
Desirable,
to understand oral disease and occlusion.
Yeah, I kind of agree with you because unfortunately, I think just focusing very soon into a specific sub-speciality, because, cosmetic composite bonding is not a sort of specialty per se as prosthodontics
It's not.
might be. There is the risk, and unfortunately, I see that in some of the cases that they get referred to us, a little bit of losing sort of control of everything else around the aesthetics. Might be the perio, might be the endo, and crowns on infected teeth and that sort of stuff. Composite bonding, just focusing on that aspect, losing everything else. Going back to some tips for dentists that they are obviously enjoying this part of dentistry more and more from you in terms of maintenance. So composite bonding goes on, patient is super happy. What happened next? Do you give them a sort of maintenance plan as such?
Absolutely.
Right. And what does it consist of?
It's a very strict. I go through this verbally. I write this on emails to patients. I give it to them on a written consent form. That unless you've demonstrated that you can look after your teeth well and that you can clean interdentally, you shouldn't even qualify for having composite veneers, because they need meticulous cleaning. Your attitude to seeing a hygienist, just by having some dental work done, you got to see the hygienist 2-3 times a year, especially
right, so
with composite.
What about polishing them
Yeah,
over
absolutely.
their life?
I mean, what I tell
improving the
patients
aesthetics.
is that they should expect an annual maintenance budget.
Okay, so once a year, right?
Absolutely, and I give them a figure, which it doesn't matter now what's the objective number, but it depends on an hourly rate that I will spend in order to do a repair.
How long it will take?
So the patient is already aware that, hey, the aftercare is significant here. Whereas if you don't want to see the dentist's face for another 10-15 years, well, put your hand deeper into your pocket, my dear patient. Accept having your teeth shaved
the blunt
down.
Approach, by the way.
Well, it's listen. Ceramics cost 3 times as much or 4 times as much. So have the teeth shaved down and go for ceramics. So the baggage that comes with composite is significant. The hygienist, the annual polishing. I train the hygienist what to use: some epitex strips or metal strips, some spiral polishes that I give the hygienist to freshen up the composites. I will only be involved if there is a genuine fracture, if there is something that the hygienist cannot deal with. But the patient knows about it and is not expecting a free repair.
In terms of fracture of composite in sort of, let's say, 5x5, which is very often what I see, or 6x6, composite bonding, do you see many fracture with contemporary materials, or is it something that it is quite unusual these days with its super heavily filled composite?
I'm currently carrying out a clinical performance study. I've known my own cases, composites chip. It is expected to have one tooth to repair once a year.
That's quite a lot, right?
It is. It
yeah,
is.
And patients need to know that.
I don't want to preempt the outcomes, but if you do, let's say, 10 units, I would expect one tooth to need a repair roughly every year, maybe a year and a half. So,
do you give them a mouth guard as sort of?
Oh, an appliance goes as standard.
Standard, right? So every single patient is encouraged to wear
absolutely.
an appliance.
Nighttime is not the only time that things can go wrong, because during the day we can brax and we can function. So maintenance is high. For composites.
Right. And patient
needs to be aware of this. And especially the very young people who just want a quick improvement, that, hey, my friend had composite bonding, as if it's a haircut. No, it's an important decision.
You're listening to the UK Dental Specialist podcast. If you're a dentist or dental professional looking to enhance your skills, explore our UK Dental Specialist courses, from hands-on composite bonding training to advanced endodontics and much more, led by experts at the top of their field. And for patients, join us at one of our open days throughout the year to meet our specialists and learn more about the treatments that could transform your smile. Find all the details and upcoming dates at ukdentalspecialists.co.uk. Follow our social media, Instagram, Facebook, YouTube and TikTok. Link in our bio. Now, back to the podcast. Right, Kostas, lots of dentists, they are learning about these new techniques, but let's be honest, some dentists, they've been trained, as you mentioned before, at university, these things, they didn't get taught during undergraduate student studies, so they're trying to learn now. So from your point of view, where is a good place to start when we're looking into, so just attend a course maybe with yourself or one of the sort of experts and take it away, or just through the dental technician, they can just communicate with them and start from an easy case? Or do you think there's single tooth, two teeth? Probably that's not a good idea. I have no idea. So where is a good place to start?
A couple of pieces of advice. First of all, an analogy from university. Many of my students, they know my background and my passion for fully guided composites. So both undergraduates and postgraduates, they were asking me to teach them how to do fully guided composites. Well, I refused. Right. I was pushing them to learn how to shape a tooth in wax or composite or a temporary crown and perfect their freehand skills. Because unless you know anatomy, and that takes years to perfect, unless you really know anatomy, you will not be able to appreciate and implement fully guided composites.
Maybe adjust as well, because I guess with injection molding, sometimes do you need to intervene freehand afterwards?
It's not so much on the correction, but it's more on the planning.
Right.
So the magic of injection molding is about the communication with the technician of, hey, this is where I want the teeth to be. And that prototype, that design, that wax up, being exactly what the dentist wants and subsequently the patient. So if the design is right, anybody can go ahead and implement it. That is the difficult part. So unless we really know anatomy and line angles and transition lines and secondary anatomy, we're not going to be able to implement fully guided composites. Similar to implant surgery, unless you know how to do it freehand, fully guided implant surgery is not going to be a slam dunk. So the second piece of advice is for a patient who is seeking cosmetic improvement, for the dentist to exhaust all potential of finding where the teeth need to be. I describe this through the process of a mock-up, which is a reversible, non-committing way of going into the changing room and trying things out, because that is the best way for consenting, rather than me as a dentist telling somebody, I know how your teeth need to look, I'm going to give it to you. Well, what if they don't like it at the end?
Fair enough.
Then I'm stuck financially and professionally. It has failed and I have to start from zero. So figuring out where the teeth need to be with direct freehand mocking up, taking a little bit of composite and just shaping it yourself, or via a lab asking for a wax up for 4 units, let's say, and doing a bisacryl mock-up just to get the patient's approval, because then they will absolutely, they will see the destination before you've committed anything. So
I mean, this is obviously, there's been a huge progress in terms of design of, smile design is often referred to. But obviously technology is just going super fast.
Absolutely.
Without getting to AI, which I'm sure will have a huge role even in this sort of field. But I can see very soon a patient turning up at our practice and us taking some sort of 3D scan, and then a computer will generate the ideal smile, taking everything into consideration, and us printing a sort of a guide and then injection molding and then do it there and then. Are we close to that sort of thing? Is it desirable, first of all? And, is it just something that will never happen, or is it happening?
Digital technology has evolved and changed the way that I practice the technique and teach the technique. What you just described is what we actually do right now at ProsthoWorks, of going completely digital and having everything coming off a printer in terms of stents. It will also revolutionize things in the next few years in terms of being able to show somebody in their mouth how things would look through printed mock-ups, because until now they just looked rubbish. They look
also at the moment they're looking at on a screen, because there are loads of softwares that can do that for you, right?
That is a bit misleading, in my opinion.
Right.
It's I experienced that when I went to buy a bathroom, and I put on the goggles and I could see this amazing bathroom. And once it was installed, it was like, oh, that was all. So there's a lot of marketing manipulation. Whereas if you go,
I guess from our point of view, if patients' expectations are not met,
absolutely,
there will be huge implications.
That's not the same as you showed me on the screen. Whereas when you go via the mouth, it's a no-brainer. So the patient gets to feel, lick, see how things look before they give the approval. So that's how injection molding.
I guess the implication from the bathroom council is not as big as our regulator, but I guess that's part of that sort of possible pitfall, promising something that we can't.
Absolutely. I mean, aesthetics is subjective.
Yeah.
Everybody comes and tells me I want bigger, brighter, better. I want a nice smile. But they don't go into details. They do go into details at the end.
Yeah.
So you can't make any assumptions. So consenting, shaking hands, and agreeing on a result before you even touch the teeth is super important, and it saves a lot of misunderstandings.
Yeah, I guess that is something that has to be always the starting point, for any part of dentistry, but possibly even more important when is a subjective assessment. When talking from an endodontic point of view, as healed or hasn't healed, I'm not going to ask the patient if they like the look of the root filling. Nobody cares. But, you've got a sort of a third layer there. It's something that you can't control, is what the patient perceives. And I guess, informed consent becomes even more important. But going back to, something exciting that you think is going to happen in this field. So you think now we're moving more towards computer-generated stents and probably a faster flow. How far are we? So you are already using that, you said, the ProsthoWorks is something that you see being implemented soon, where we can skip the lab And then, we'll all love our technicians, by the way, and they will be around forever. But do you think that's the trend? Is that the next step?
It is definitely going to get more digital. It is going to get more AI driven. Things are going to get more fully guided, and it's unavoidable. It is unavoidable. Whether that is the case of taking a portrait picture of somebody and just designing the whole smile based on a single portrait. So all the big international companies like Straumann and Invisalign do exactly this. So a fast-forwarded smile design of just very basic but good quality diagnostic records. So more and more printed information will be involved, more and more CAD designs rather than a man-made wax up, and it has its plus and minuses. There's nothing perfect with a fully digital world. There's always a need for some manual touch-ups and corrections. But
the workflow is
that's
quicker.
Where things are going to go, where an AI software will design the crown so that I don't have to on a CEREC unit. So that is going to rocket in the next
That's the
years.
next step. Well, Costa, thank you very much for your time. I'm sure the listeners enjoyed all the tips and advice that you gave in these sort of nearly 40 minutes or so. There will be more episodes similar to these. We will have some other experts in the dental field. If you have enjoyed this episode, please subscribe. It will be streamed through different platforms. So there will be our YouTube channel and most likely Spotify as well. But obviously we will keep you up to date where to find the next episode. So thank you very much for listening, everyone, and thank you very much, Kostas. And I will see you at the next episode.
Thank you, everyone.